Well, good afternoon, everybody. I think we will make a start. Welcome to this session, which is taking a very deep dive into the work that's been going on in Zanzibar. We are currently waiting, unfortunately, for our chair of this opening session, Saidi, but hopefully he'll be with us soon. I think he might have got a little bit lost outside, but hopefully he'll be with us soon. But we've got a very interesting session coming up. We just have the next slide. Got the next. Progress the slide. Oh, we've got it. Yeah, so I think everybody's seen these housekeeping points before. We just go through them very quickly. The meeting is being live streamed to our virtual platform. We're going to pause when the session breaks. We're not, in this session, going to go into smaller group discussions because we're a fairly small group and we want to capture everybody's ideas from the different areas. We want to have that discussion together. So we're going to have detailed questions and answers after the topics and then go back in more detail a little bit later. And the next slide. And the next. We're going to work around these four presentations. We're extremely fortunate we've got our colleagues from Zanzibar with us today, Charlie Amy, who spoke this morning actually a little bit in one of the MDA sessions, and also Dr. Fatma Kaboli, who hopefully will be joining us shortly. But as you probably all know, Steffi Knopp from the Swiss Tropical Institute has been very instrumental in leading the elimination program in Zanzibar in recent years and look at these questions around endgame challenges. And some of us were in a very interesting session prior to lunch where we were really trying to drill down into what do we do in these endgame situations. And although it begins to sound as though it should be fairly simple, as when prevalence has fallen and the situation is not quite as serious, we are very much aware now that to actually reach that stage of what we might call interruption of transmission, it's not going to be an easy task. It's going to take a lot of effort and possibly a lot of time to actually achieve that. In Zanzibar, as we've heard, we've reached that stage where we have elimination as a public health problem. That's fine, but how do we sustain that? How do we maintain that? And if we really do want to go to interruption of transmission, what's next? What can be done? How cost effective is it going to be? So we're going to drill down into some of these questions as we go on this morning. We've got Steffi giving a general overview of the work that's taking place, giving some idea of the interventions that have taken place, the prevalence, etc. Bonnie Webster from the Natural History Museum is then going to go and jump in and give a detailed account in relation to diagnostics. What diagnostics do we need? What diagnostics have been used? And then Charlie's going to come in and talk after the break. I think at that stage you're going to take the break. Then Charlie will come in and discuss some of the questions relating to environment. How do we go about checking for transmission? How do we find places where snails might be? What do we do in these kind of situations when water development projects are ongoing, when the environment is changing, climate change and the sort? How do we handle this kind of situation as we approach the end game? And then Dr. Fatma, who's now higher in the administration of the Ministry of Health, is going to give us a little bit of her insight into some of the thinking within government, some of the questions that are asked within the Ministry of Health as to how can they actually help with these interventions and the control strategy. Because, of course, it's not easy. If you've actually achieved elimination as a public health problem and you want to go to the next stage, interruption of transmission, it's a big step. And is that still going to be a priority for government to take that step? So hopefully we'll jump into some of those kind of discussions a little bit later. So I think without any further ado, I'll hand over to Steffi for the first presentation.
Yeah, hello everyone, and thank you, David, for jumping in for the introduction. Welcome, Amadou. And I hope we have covered the schedule. And we are now getting to the first talk, where I will present you about the successes in Zanzibar over the past years. And also focus a little bit on the challenges on the way towards elimination. So you will realize, if you have been in the morning session where Charlie presented, that there are some slides that you will recognize. I will not duplicate the content, but provide a little bit deeper information on these slides, so don't be annoyed if you see them again. So again, as Charlie said this morning, today's topics and the particular topics of this sessions are Schistosoma haematobium, because that's the only species that is endemic in Zanzibar. We do talk about the islands, Unguja and Pemba, that belong to the United Republic of Tanzania. They are wonderful islands for tourists. They are paradise for people that like beaches, but they are also a paradise for parasites, including Schistosomiasis. And we talk about the elimination of this parasite from Zanzibar. So now, again, you have seen that slide this morning, potentially. In the last century, in the 1960s, we really still had high prevalences of Schistosomiasis in Zanzibar. But over the years, and thanks to a lot of research, but also successful control, large-scale control and elimination interventions, prevalences were decreased considerably. And in the 2012 area, when SCOR and the Gates Foundation started to step in with elimination, operational research for elimination, we were around 10% and below. And what we then had as a first elimination program was the Zanzibar Elimination of Schistosomiasis Transmission Project, where we had a cluster randomized controlled trial that assessed in 3 arms the effect of biannual mass track administration, not only in schools, but also in communities, and in some randomized areas added snail control or added behavior change interventions. During that period, from 2012 to 2017 of that cluster randomized trials, the prevalences and also the heavy intensity infections were reduced like from around 6% to 2% or below 2% in school-age children on the left side, and from around 4% to below 2% in adults on the right side. And that was, again, due to biannual MDA and in certain areas, snail control or behavior change interventions. And that also due to low intensity infections, we in 2017, or Zanzibar in 2017, had achieved elimination as a public health problem as defined by WHO. So heavy intensity infections were below 1%. The prevalence in 2017 was below 2%. And those people that were positive really had extremely low egg counts, most of them. So even below 5 eggs per 10 milliliters. So not a lot to detect in a urine sample. So we really thought and hoped interruption of transmission may be possible. And when then Amadou presented at some point for the WHO, he listed the countries that should be targeted for interruption of transmission by 2030, and Zanzibar was among these areas. So interruption of transmission is really the goal to talk about. But how to reach it? Again, we have the new guidelines from WHO that say that in countries or in areas below, or communities below 10%, we should continue with preventive chemotherapy at the same frequency or reduced frequency towards interruption, or change to a test and treat approach. But the evidence of whether that works is actually quite low, and we need future operational research into that direction. So now, what we had in Zanzibar, going back to that, is a reduction of prevalences to quite low levels with biannual MDA plus complementary interventions. When SCOR stopped, Zanzibar went back to annual MDA only, no additional interventions. And there was even a gap of MDA between 2019 and 2020. And what we see is prevalences do not further decrease, or a little bit in adults, but it seems there is, well, a leveling off or maybe even a rebound. We don't know. Unfortunately, the monitoring surveys have stopped since 2021, since no more funding is provided, so we don't have any data for 2022 or 2023, but the annual MDA actually did continue. So now, we get to our first challenge, and the question whether MDA or at the same or reduced frequency can reduce or move towards the interruption of transmission. We have seen in Zanzibar that was not the case. MDA alone at the same or reduced frequency did not result in interruption of transmission. Why not? What could be an explanation? Why is MDA alone not sufficient? I think we have discussed that a lot already in previous meetings. One reason, of course, might be the low coverage and especially the compliance in the adult community. So what we hear a lot in Zanzibar is that adults do actually not want to take the drugs in MDA because they feel quite healthy and they don't want to take that many pills together with albendazole and ivermectin and then the bitter pills for praziquantel if they feel healthy. And if you think about yourself, would you, if you feel healthy, just take pills that are provided to you? Also in Zanzibar, pregnant women are not treated during MDA. And they also say they don't want to. They don't want to risk anything for their unborn baby. They would accept that in a health facility by medical personnel, but they don't really trust the people that knock at their doors. And also people often are not aware of the consequences of schistosomiasis, and when we have health education meetings and talk about infertility or bladder cancer or anything that can happen in chronic schistosomiasis, they change their mind and say, oh, actually next time I might take the drugs during MDA. But it's really something we need to keep in mind. How can we increase coverage and compliance if we continue with MDA, as well as with other interventions? Another point that why MDA alone will not result in interruption is that praziquantel does not have a cure rate of 100%. And then in Zanzibar, we have had more than 16 rounds. I think in the meantime, we are approaching 20 rounds of MDA. So how about potential resistance development? Do we need to look into that? We don't know. We don't have any evidence for that, but it might be worth to look at it. And I just pointed out in small letters potential operational research questions that we might ask in that regard, and that is how can we increase compliance and how good is the cure rate of praziquantel in Zanzibar? Is there any sign for resistance? And that's just something to keep in mind for the discussion later and for operational research. So now, we get to the next challenge. The next challenge also was flagged in other sessions. That is the heterogeneity of transmission. So what you see here are maps from Zanzibar. That one is Unguja, that one is Pemba. And you see a lot of green dots. And in these green dots is indicated what we found in the surveys over the past 10 years. So if you see mostly green and light green, that means in all 10 surveys over the 10 years of SCOR and after, we had really extremely low prevalences. And that would be across a time of 10 years. But you see other areas where there's a little bit of red or yellow or orange, and those are the areas where there's probably higher transmission and where there is sometimes recrudescence, sometimes higher prevalences. So those are the areas that we call hotspots, even if they might not have high prevalences, but still they are different to those areas that were and probably will always be in light green or green. So there's many areas with a low potential for transmission, and there's a few areas with a high potential for transmission. And operational research questions in that regards is that we need to know why are these hotspots. We don't know whether it's to snails or behavior or other resistance, other issues. And then also how should we address this heterogeneity in the future? Not with blanket MDA anymore, but with other approaches. And then also if we look into recrudescence, I mentioned this treatment gap of 16 months between 2019 and 2020 at the beginning. And what we had in 2019 were really nicely low prevalences. So the blue line is the male population, the red line is the female population, and down here you see the ages, starting with 5, going to 80. So we had prevalences throughout of below 2% in 2019. But then we had the 16 months treatment gap, and suddenly we observed a huge increase, a recrudescence in boys in particular, but also in girls aged between around 9 to 16 years. But where did this occur? So we looked into those hotspot areas and low prevalence areas, and what we actually saw is that in the low risk areas, there was not much of an increase due to this treatment gap. But in the hotspots, we had a quick rebound of high prevalences to up to 10%. So again, thinking about operational research question, we really need to make sure where, at what prevalence, and how we can stop MDA. And then if we want to maintain the gains, which interventions do we need for that? And if we want to accelerate interruption of transmission, again, what interventions could do so? And that's something we also discussed in Maurice's and Rachel's discussion breakout group before. So now, if we then look at a newer project, the Schistobreak project funded by the Swiss National Science Foundation, is looking a little bit into this heterogeneity. So we define in cross-sectional surveys hotspot intervention units. And again, if you look at the prevalences of a little bit larger than 2% in the community and larger than 3% in schools, as defined as a hotspot, that's not really a hotspot as you might think about it. But still for us, those thresholds were used to define a hotspot, and these hotspots get everything because we want to reach elimination. So we have, again, school and community-based MDA, stale control, and behavior change. Not randomized, but specifically assigned to our hotspot intervention units. In the low prevalence areas, we follow a totally different approach. We don't have MDA anymore, but we use a so-called surveillance response approach, and that also includes a 5T approach that we have been talking about this morning with Kenya. So what we do here is that we conduct active surveillance in schools. If we find a positive individual, it's treated with praziquantel. It's followed to the house, where we offer testing and treatment to family members or household members. Again, positives are treated. And also these positive children are asked which water bodies they are using. We offer testing and treatment to people that also use this water body, and we also check for snails. We send our snail team. If they do find snail, they also do reactive snail control. And we do work also with health facilities in the area for passive surveillance. Again, if they find a person with positive symptoms and positive hemosticks, they would treat that person. So now, in terms of results to that surveillance response approach, it's still ongoing. We will have the final data early next year once the study is concluded. From the first year, we saw that the test treat track did not do much, which was good, actually. So what you see here, and I'm really sorry that the screen is so small. So here you see results from baseline community survey and baseline school-based survey. And a year later, in the same intervention units, we did not see much of an increase in community and in the school. So it managed to keep the prevalences low. But in terms of, and that does not really totally fit into the graph, but I just wanted to show you what percentage we found in the positive children's households on the left side, and in the positive households, positive water bodies. So the positive children that we identified in the schools and tracked really led us to a lot of positive people in their households and at the water bodies. So the test and treat approach did not manage to decrease prevalences, but it led us to positive people, and that, I think, alone is already a success. In my view, we really need future studies to see whether the 5T approach can maintain can maintain the low prevalences, might even reduce them. Personally, I doubt that. But for sure, it's a way to identify positive people and then, of course, to treat them. So it might be a tool to maintain the status quo, but it might also be, if it is used in areas with higher transmission, that we do observe recrudescence, and that the Schistobreak study will show, like in this year's results analysis. So operational research questions here is really, can recrudescence be avoided when test and treat or surveillance response is implemented with a high coverage and frequency? Because, I mean, as MDA, coverage is key, and it cannot be done by 4 people, a test, treat, track thing. We need a lot of groups doing it to achieve a high coverage. And then which interventions, test, treat, track, or others, can help to maintain the gains? Which ones can help to accelerate interruption of transmission? And we should definitely also think to other alternatives to large-scale MDA. Not only test and treat, but focal MDA, for example, near water bodies. So my final slide, because that's leading into Bonnie's presentation, is the challenge of the low accuracy of the standard diagnostic tests, in particular for Schistosoma haematobium, where hemostix is the only rapid test that we currently have. But hemostix does not really perform well for low egg counts. So what you see on the x-axis here are the egg counts. Here's 10 eggs per 10 milliliters. And everything below 5x, 1x, you see the sensitivity rapidly decreases to around 50%. So it's a 50-50 chance if we use hemostix really for a test, treat, track approach. We will miss a lot of people. And we will, of course, also have some wrong positives. We have more sensitive tests, like the UCP-CAA, but that's a laboratory-based test. It has a higher sensitivity, but it's not applicable at the point of care. So we really need to think about when and how we can get a rapid diagnostic test for test and treat approaches and health facility use for test and treat. So operational questions here could be, so what would be the performance of the new point of care tests and elimination settings that are currently in the pipeline? And then also, which tests should we use to really determine prevalence thresholds for stopping MDA? And which tests can be used for test and treat and or surveillance or validation of elimination? And with this, I think I hand over to Bonnie. Thank you for your attention.
So thank you, Steffi. And I'm really going to just lead on from Steffi. I want to reiterate some of the challenges we face. And this is really focusing on diagnostics. And throughout many of the presentations, throughout COR and in the plenary, it really, there's a lot of, diagnostics is critical for all of the NTDs in terms of control and elimination. And it's central to so many aspects of control and elimination, particularly for schistosomiasis. It tells us about our true prevalence levels, how we make those decisions on the thresholds for MDA. It allows us to design more targeted, appropriate interventions. It allows us to actually assess our interventions as well. And it's really needed for that long-term monitoring and surveillance. So it's a really critical component going forward. But for schistosomiasis, we know we have diagnostics which we can use at the high prevalence and intensity levels. Microscopy is very good, it's very specific. But as we move down and we move away from morbidity control to infection and transmission control towards elimination, and also past elimination, our tests need to become much more sensitive and specific. And then we need to be designing our treatment strategies and moving away from MDA to more test and treat scenarios. And we need to think about the future. We need to think about that long-term surveillance and how we're going to do that, because that's a critical component, and it takes time to develop these strategies, so we need to have those ideas in mind now. But when we design diagnostics, and so I work on diagnostics in the lab, there's a balancing act between specificity and sensitivity of diagnostics, and the more specific a test is, often the less sensitive it is, and vice versa. So again, when you're designing those diagnostics, you need to take both categories into account, and that's what the target product profile for schistosomiasis actually brings together. Steffi showed this table, the countries that are earmarked for interruption and transmission going forward. But again, how is that interruption and transmission being determined? We talk about these goals, but what diagnostics are we using? And we have no idea. We're talking about, so it's all the prevalence data that Steffi showed is, again, what is the diagnostics that's giving us that data? So the target product profile for schistosomiasis details the ideal diagnostic characteristics that we need for two different scenarios, monitoring and evaluation. And for that diagnostic, the specificity of the test is very, very high, and the test itself should be much more less sensitive. And then for interruption and transmission, the target product profile says that this should be a two-step test. The first test should be highly sensitive, and then the second test should be a more specific test. So again, it's not just a one test for all of these different scenarios, so you have to think about them individually as well. But what happens when we implement a new test into an elimination setting like Zanzibar? Will our prevalence levels go much higher? And what does that mean? And then what do we do? So we need to think about that as well. And this is what we're finding in places like Zanzibar as well. Also for schistosomiasis, the disease is complex. There's two main forms. We're just going to talk about urogenital today, but again, we should never forget that there's also intestinal schistosomiasis. And so the diagnostics that we develop are different for those different use cases, and also the different kind of samples that we target as well. So for urogenital schistosomiasis, again, we should also not forget other morbidities such as female genital schistosomiasis. We're not going to talk about that today, but we also know that there's a need for those diagnostics for those hidden morbidities as well. So we have microscopy and hematuria, as Steffi has pointed out. We have DNA tests, and we also have the much newer CAA test. Again, very much in a laboratory setting, it's highly sensitive. And now we know there's a lot of work to try and get this into a point of care test again, but that's not easy either. Again, we can also use blood samples for these DNA tests and the CAA tests as well. But what are the tests that are going to be very, very useful for elimination and interruption of transmission, where our aim really is this really highly accurate testing, and the objective is really to stop forward transmission by those few people, and it's very few people that are actually infected that we need to find. So for those active low-intensity infections that we need to determine, in lots of the literature, it's suggested that it's the DNA tests and the CAA tests that are going to be the tests going forward. But again, that can be debated. There's a lot of work on the AI of microscopy, for instance, that could be useful as well. So in elimination, it's both the DNA and the POC-CAA and the lab-based CAA test. But then for interruption transmission, the sensitivity has to be much, much higher again. And so this lab-based, very sensitive CAA test or DNA tests are going to be the ones which might be able to give us the best data. Also, for interruption transmission, we need to think again about the future, again about that surveillance aspect, so developing good antibody-based tests to actually detect exposure as we go forward beyond elimination. And also, diagnostics, it's not just about finding those people, those few people infected, but it's also to prevent those hidden morbidities. We still don't know how much morbidity is associated with a very low level of infection. So again, diagnosing people is very important to actually prevent that hidden morbidity that might not show in terms of symptoms until very much later in life. We acknowledge that many of these tests are really still very much under development. They're only used in research needs, and then there's a critical need now for clinical assessment of these diagnostics and to bring them forward so they can be used actually in the areas that are needed and as part of the health services in these endemic countries. So some of the questions we have is, can some of these diagnostics really be moved forward for test and treat scenarios, such as those scenarios that Steffi's pointed out at the point of care? Can they actually fit into these TPP characteristics? And again, that accessibility, which was brought out in that plenary at the beginning, are they going to be available? Are they going to be affordable? And are they going to be acceptable as well? So those are the kind of things that we need to think about. So Steffi showed this slide, but I just wanted to highlight here the gains that have been achieved in Zanzibar. A lot of those gains have been based on the basic microscopy diagnostics and looking for blood and urine samples as well. So they have been very useful, and they have brought down prevalence and intensity of infections to a very, very level. But now we're at this critical need where we're at this low level, and we really need those high sensitivity and specificity tests. This is just a snapshot of some data looking at microscopy in terms of egg counts. And we know that when we get down to very low egg counts in urine samples, between 1 and 4 eggs, our sensitivity of our diagnostic drops by 71%. So that's quite considerable in terms of the lack of sensitivity in that test. So that's why we need these more advanced tests going forward. And again, bringing up these guidelines by the WHO, where it says at or below 10%, what should we do? They suggest that we continue that intervention at a same or reduced frequency towards interruption and transmission. But again, how are we evaluating that? And then to bring in these test and treat scenarios. But again, there's no recommendation about how we do that as well. So I think more detail in these guidelines is very much needed. We need the diagnostics to actually define our true prevalence. We need to think about if it's actually to continue the status quo. Will that actually lead to interruption of transmission? We don't know, as Steffi has pointed out. Is continued MDA in these these elimination settings actually acceptable, and is it possible? And as Steffi pointed out, a lot of people in places like Zanzibar are they're MDA fatigue. They want a diagnosis before they take the treatment. And again, will that actually increase compliance? So just to reiterate about the low accuracy of the current diagnostics we use in Zanzibar, and I won't go into too much detail because Steffi covered this very nicely, is that hematuria lacks sensitivity as we get to very, very low egg counts. The CAA again, and I really want to point out this bottom graph here where we're comparing CAA in red to egg microscopy, and you can see the huge discrepancy we get when we start to implement these more sensitive tests, and we question a lot about what that actually means. But again, you can look at some of these villages, and you can see the jump in prevalence is quite significant when we apply CAA testing. So yeah, that discrepancy is a big question going forward. And again, that also comes out when we do molecular testing. This is a very brief snapshot of some of the molecular data. We know that we get some samples that correlate nicely, but then we get big discrepancies. So the bars show DNA on the left and then eggs on the right. We get samples that are DNA positive but egg negative, which we can explain quite easily. But when we get the reverse, we get them egg positive but DNA negative. That's more difficult to explain. Again, so we need to understand this a lot more and to actually advance our diagnostics to actually do really detailed comparisons. So this always makes us question our true prevalences. We also lack this gold standard about how we evaluate these diagnostics, and this is a continued discussion around people that use diagnostics about what are we basing all of our data on as well. Just to reiterate this problem of recrudescence with schistosomiasis, and here just point out that treatment and diagnosis go hand in hand. When we have inaccurate treatment or inaccurate diagnostics, then we really run this risk of recrudescence, because we can't remove those risks of the transmission itself. When we miss a single person infection, snails become infected, and due to this multiple replication stage in snails, then we lead to more people infected. And again, this cycle goes on to lead into many more people in the population infected. And this doesn't happen slowly, this happens quite quickly. The transmission cycle is about 3 months. So within 6 months, we can go from a very low level to quite a high level. And again, we need to make sure that we keep implementing and monitoring these scenarios going forward. So what are the operational research questions for diagnostics for Zanzibar? So there's two kind of areas here. There's the very applied aspects, is the performance of new developing point-of-care tests in elimination settings. Can these tests actually determine true prevalence and the true prevalence threshold for making those decisions about MDA? Can these tests actually be implemented at the scale that's needed? And that's a big technical question as well. And I think for that, we really need some really detailed comparative diagnostic studies, and that's something that we'd really like to do to actually bring these diagnostics together and to see what their performance is. And then the not quite so applied aspects of diagnostics about what diagnostics can help us with. Can acceptable and more accurate diagnostics increase this treatment compliance within the community? And I think that it can. Can better diagnostics inform on our actual cure rates? So can it actually tell us more about how the drug's performing? Will it help prevent this recrudescence, which we're very worried about? Can it actually give us more information about hotspots versus non-hotspots? And again, I think we need to just not have a blanket approach within our diagnostics. We might need to tailor them to different areas. And then again, how do we implement them and where they're going to implement it? Can they be implemented in schools, water bodies, and situations like clinics? And back to that, we'll test more advanced diagnostics. Will they help with this test, treat, track approach that Steffi's mentioned? So for that, I suppose we need this country-wide, multifaceted, interdisciplinary, longitudinal study approach. So a big project, but that's what we need to do. And I think Zanzibar, I just want to finish off by saying Zanzibar is an excellent case study for elimination and bringing all these different components together, and can be used as a model for other areas going forward. And in Zanzibar, we're at this pivotal role in elimination of schistosomiasis. So it's been a long push to get there, a lot of effort by multiple people. I think we can just stop and just see what happens or just continue, but again, that really runs the risk of going backwards, and we really don't want to do that after all this effort. We need better diagnostics now to really push forward. We need to think about the logistical aspects about, and this has been brought up, who's going to pay for them, and also that access and sustainability. We need that long-term monitoring plan. We need to also consider other aspects about importation of new infections, movement of people, which is also a real risk, which is and how do you monitor that? In terms of diagnostics, I like to think about the whole picture as well, and about diagnostics for the environment and also the snails, and that's particularly why I work on molecular diagnostics, because it's a platform that can be used across the board. And then one of the kind of areas as a researcher which I particularly struggle with, and I know many do, is about all the paperwork around sharing and the ethics of samples. And we really need those really high quality biobanks that we can test multiple diagnostics on. And I think I'll finish there.
Want to come, Sandy? With me? Oh, okay. You can do the next session. Okay, thanks very much indeed, Steffi and Bonnie, for that really deep dive into Zanzibar. I'm going to suggest you both come forward so we can put you in the spotlight. We can turn that off. Perhaps come over here. Or can we turn that off, perhaps? Sit, stand, do what you like. So we heard there a lot of detail, and both speakers very kindly put up a number of operational research questions. I think one of the things we want to do in this session is to learn from you, to learn from the audience as to what do you think should be done next in this kind of situation, and what do you think are the next steps in Zanzibar? So who would like to jump in first? Oh, lots of hands going up. Right, I think Anna was first.
Hi, Anna Phillips, FHI 360. So I have a question about the pregnant women not wanting to take treatment, which I completely understand. So does Zanzibar test in antenatal clinics? Because if you're testing pregnant women and they test positive, they know they're egg positive, then they can make an informed decision that actually being positive might be more detrimental to their unborn baby's health than not being treated. So is that an option? Has it been done in Zanzibar?
Yeah, so I don't know, should I use can you understand me? Or?
Have we got another microphone in the room?
I can shout as well. So, I totally agree. So we had a qualitative study done like a few years ago where we really had interviewed women coming exactly for the antenatal care, asking them whether they would be ready to take praziquantel, and they exactly said what I said. So they are not so happy to take it during MDA when there's drug distributors coming from house to house, because they might not know the person, they might not trust the person. But if they get the advice from a medical personnel during exactly that service, then they make an informed decision. And if there's a possibility for testing and then taking treatment, that would of course be even more acceptable. So, but I don't know, I would let Dr. Fatma and maybe Charlie respond in whether that is planned for the future now that health clinics are more getting into the focus. I don't know, Charlie, Dr. Fatma?
Yeah, so it's more of a policy question, actually. We tried to look through the regional data, and there were not enough evidence around the region, like from Kenya, Uganda, and our surrounding areas, including Tanzania mainland, where praziquantel is offered to pregnant women. And the government was actually very reluctant to offer praziquantel to pregnant women. So up to now, if the woman is positive, then definitely they will be offered praziquantel after the second trimester, is it? Something like that. But if they are not positive, and if they cannot know if they are positive, as you have seen, it won't show. So there's a balance there. Is how do they know until the hematuria is gross, then they would know that, you know, they are positive. They would seek care because it's not actively being done at the antenatal clinic.
Yeah, so I guess my question was, could you actively test in antenatal clinics so that you then have data?
So for testing, I think that can be done, and it can start as a pilot. But testing widely, I think it's a matter of resources as well. The government now is going through a very big health sector reform process where we are actually doing a whole lot of health system strengthening work, where we are renovating the health facilities, making sure they are lab and diagnostics. And so now I think it can be done. But I leave it to the wider Schisto community to help us decide on that.
Yeah, and maybe it gets back to the diagnostics. I mean, what diagnostics would they have? They could be easily provided with hemosticks, but especially in pregnant women, does it make any sense to use hemosticks in an elimination setting? Probably not, and then it gets back to to microscopy or not available diagnostics tests. So it remains difficult at this stage, and until we have a reliable point of care test, I see it's a problem. Yeah.
A related question, which I don't think has been done in Zanzibar, is the importance of FGS.
Yes.
Please.
Thank you, Bonnie and Steffi. Luc Koffeng from Erasmus MC. I was interested in your findings from the low endemic areas where you applied the 5T strategy. The cases that you identified, were you able to link the locations where they went to the water or maybe picked up the infections? Were those linked to the hotspots or not? That might be very important for what the value of your diagnostics are going to be in the end.
Sorry, David.
Yeah, go for it.
But yes, so we have done the geolocations of everything. So we do know where the child lives, the positive child, and we do know all the water bodies that it's using, and we can map them. They are both. They are within their own catchment home area, like smallest administrative areas, but some of them also go to hotspots. So it is a bit of both, really. It's it's not only that they get infected in neighboring hotspot areas. It's both.
So there's potential for local transmission even in those.
There is.
The low endemic.
Yeah, there is. Yeah, and again, I mean, we do a lot of snail surveys, so and it is exactly this. So the children would indicate like a few water bodies. Most of them do not only use one. I mean, if there's only one, they use only one, but they might even go to 5 or so. And it's between a 1 kilometer to 10 kilometer distance, really, that they cover. I don't know if they visit a relative, if they go 10 kilometers apart, but yeah, it's everything.
Okay.
You got the microphone.
Thank you. Is it possible to have the previous slide of Bunny? Yeah. Because I would like to make my comment based on that.
Okay.
I would like to acknowledge and thank the presenters and the country program for all the progress that the country have been able to make with the available diagnostic and the available treatment and the strategies for control, meaning the snail control, the MDA covering all age groups, not all age groups, because the preschool age children are not included, they have not been included in the treatment. The preschool age children using crush tablets.
Yes, they are.
Okay. Good, and also behavior change, etc. But yes, this slide. Because Schisto is due mainly, as I said, to, it's linked to socioeconomic development and to behavior. And you see, these 3 images that you have, unless you are able to stop this contact between a human and the transmission site. And this is due to the socio-economic and development in the area. The transmission is not going to get to zero. It's going to be zero, not now, but maybe in 15 or 20 years, because you will still have the transmission going on. And the second point is that even if you are able to stop people entering these points, you are not going to stop new transmission, because from experience now we know that when you have infected the snails in a point, the transmission can run for many, many years. And one of the examples is the transmission of schisto in Corsica. It started in 2011, and even 2 years ago, people got infected in this place. What does it mean? That maybe the snail continue to release cercaria? Or do we think that people continue contaminating this place in Corsica? So I think it's really important to focus on health education so that it will be possible to limit the contact between people and the water plants. Continue to do this health education to have much more acceptance of the treatment from people, all ages, including pregnant and lactating women, as recommended by WHO. Because I don't think it's something that is going to be solved by diagnostics. Actually, yeah, but improving, I think, the treatment strategies, how to do the test and treat. Is it going to be done at community level, in going house to house to improve the number of people treated? Because with other diseases also, we have this question of never treated people that contribute to the transmission of the disease. So we need to find them and provide them treatment so that we can at least cut the transmission from these people that think that they don't have the disease, but who contribute to the transmission. Thank you.
Thanks, Amadou. I think there might be some points you want to come back to on that. Or shall we go ahead? Further questions? Come and sit over here, Bonnie. Sorry about that.
I think the scenario you brought up in Corsica is quite interesting, actually, because I think the scenario there is that there's local people infected that are continuing that contamination, and those local people aren't tested because it's very different to an African setting, but they are not tested or treated, and they don't have symptoms. So again, it's a very similar situation, actually, where people are missed. I totally agree. It's stopping this contact is the critical point, but it's like, where do we go from now, really? Yeah. I think, and also just touching on the diagnostics there, we hope that better diagnostics will increase this, will help with the treatment strategies, and I think that, personally, I think that does help. When we talk about pregnant women, if we can give them a really accurate diagnostic, that they can see the test result as well, so you're actually proving to them that they're infected, I think that will help. But yeah, it's not easy, and yeah.
If I could just step in. I hear what you're saying about treatments, Amadou, and you're correct. But remember, we've had 18 to 20 rounds at NDA. We've had treatments every 6 months for a 5 or 6 year period. We've been treating the whole community, and we're still in this position. So how do you improve treatments?
Treatment, I think, as I said, it's about the acceptability of the treatment by people. It's not about only the medicines. Convincing people to take the medicine, because when you do test and treat, you're going to miss a lot of people. When you do MDA, a lot of people also are going to feel that they are overtreated because they don't think they have the disease. This is why I'm saying focus should be on this health education, on these people continuing accepting the strategies.
I
The
think
solution could be a vaccine, but
Yeah,
not
that's-
this kind of new vaccine.
WHO is saying this has to be done by 2030.
We have enough trouble with COVID.
Acceptance of vaccination is another thing.
Okay, let's move on to some of the other questions.
Okay, yeah, maybe a comment and a question quickly. Maybe you should think more about what I'm calling the human resistance, because people are focused on parasite resistance, but maybe it's time now to set agenda to better understand what I call human resistance. The issue behind the fact that people are refusing sometimes, even if the health education and drugs in several places in the world, we need to better understand that. Otherwise, we will fail. My concern is about the Islam or Zanzibar. I'm asking if you are taking into account the migration of the population. Maybe that, I don't know how is the geographical location there, but I have this concern in my mind.
Yeah, there's, I mean, what you might have seen at the beginning, these islands are really small, and yet people, it's different. I mean, people might visit their relatives, and therefore travel within an island or move to the other island. So there is a lot of movement between the islands, between Pemba and Unguja. There's also some movement to the mainland, where we know there's also schisto-endemic. But I think at the moment, I mean, it is, like we see that in malaria a lot in Zanzibar. Zanzibar is also targeted for malaria elimination, and their main issue is really importation of cases. I think for schisto, we are not yet there, but it's something to consider. But I guess, first of all, it's the within and between islands where we need to focus on, rather than even including mainland. That's music of the future.
It's a good question. We do see Schistosoma mansoni in Mafia Island. We've seen cases there, but there's no transmission, there's no snails. So clearly it's imported from the mainland.
Okay, thank you. I'm Eugene from the End Fund. I was not in this room the morning, I was online. But I want to make a comment. This is an additional challenge. It's about the coverage of MDA. We used to rely on reported coverage, but especially for praziquantel, the kids don't like the taste of praziquantel. So actually, we don't know the people who swallow the medications. So, and I know WHO recommend the coverage survey evaluations, but very few coverage surveys are implemented in the country because of limited funding. So we may invalidate the coverages, and actually this coverage may be even ineffective, but we still use this, the coverage was 100%, 90%, but we don't know the real coverage. So for me, I always encourage program teams to consider the coverage surveys in their plans. This is my comment.
Yeah, I can briefly respond to that. I totally agree that coverage data are an issue. In Zanzibar, we have really a series of coverage surveys. So we have the one done by the Ministry of Health. We have done those by the implementers, by former SCI, now Unlimited Health. And also in our annual surveys, we do ask the people where we collect samples from in cross-sectional surveys whether they have received praziquantel and whether they swallowed it. And what I showed and what I called compliance is really when they said they swallowed this, and not morning or evening or over multiple days, but really the praziquantel tablets that are the big ones, the smelly ones, in one go. So I would say the compliance data that we have are quite accurate, and they are actually very similar to what the SCI was collecting a few years ago. So there's a lot of coverage surveys that were implemented in Zanzibar.
Yeah.
Maurice?
Thank you so much. I'm Maurice Odire from Kenya Medical Research Institute. Steffi, I mean, this is very interesting because I think you guys are kind of trailblazers, so lots of lessons to learn from Zanzibar. Mine is on the consent process. From the primary index cases that you identify, what language exactly do you put in the form when we know issues to do with stigma, like you're going to test secondary cases based on the positive cases identified? Do you have challenges with that, or was that easy to deal with?
No, but it is a point to consider. So I mean, of course, in the schools we can use the normal. Well, we have the consent and information forms, which are written in quite lay language, and that it's consent forms that are provided to the children. They take it to the parents. The parents are hopefully understanding what is in there, so that the children get a proper explanation, and they hopefully expand to their parents.
So do you explicitly indicate that on the basis of your results, will disclose this to the people you play with? You have similar water contact activities, and they're fine with that, right? Because you're going to identify secondary cases based on the ones who are positive, and so you're telling the secondary cases that based on the results of X individual. Okay.
Yeah. So we would of course, because we follow the child home, and then we ask the family members, and we do explain to the family members that that child is a positive, and that therefore we would like to test the whole household. Okay. But of course that is stigmatization, if you want to say so. But again, those household members would then need to sign a consent form and these kind of things. But it is something to consider, I think, like following positive children, telling their parents, and then parents get angry and say, I told you not to go to water body, but obviously you went because you're positive. Yeah. So,
There's quite a number of things there, yes.
Just to follow up on that question, so with this perceived stigma, does that decrease uptake of the test and treat? Or did you face any sense of stigma?
I haven't observed that. It's something I should probably ask our team, or I don't know if Saidi has any awareness of there's some increase. I do somehow assume, just a first thought, I don't know if it's true, and you can comment on it, like the Schisto work in Zanzibar has been so prominent over the last 10 years and more, and people are so used to that they just ask for their urines everywhere, basically. And there's really a high acceptance and no more surprise. And if you're positive, it's, okay, you're positive. But it's bad because I might have told you not to go, but actually I do know you go. That's my feeling, but...
It's actually true. From the many years of the MDA, where we are now talking about people who have that exhaustion of taking the medication. If you come and say the child is positive, there's no stigma around it. They know kichocho as kichocho, it's like, well, no. So...
And actually, in a way, they are taking this very positive, because as we said earlier on, people are really tired of taking medication twice a year. So even the parents themselves, they will be happy that their kids are treated when they are positive already. You see, so actually, sometimes they call us, the parents, because we have our numbers in the consent forms. And then they say that it's like, oh, can we also come and check? So it's in a way, it is not that stigma, but it's also something that a relief to the community that they are no longer bombarded with medication twice a year.
So I have a question for Steffi then on that, because your test, treat and track is based on urine microscopy or hematuria, or is it both?
Well, it depends where. It's both. So the children get both in schools. So we do the hemostix in schools and the urine filtration in the laboratory. And because it's so many samples that we collect, it's actually, they do only get the result the next day. So it is not really, in a school, I would say a point of care test is not as much needed as in a health facility. So in the schools, we do both. In the households, the same. We do the hemostix at the household. We take the urine home. We take the telephone number home. And if we find a different result in the urine filtration, we would call that person. In the health facilities, they only have hemosticks, so we don't provide them with additional collection and urine filtration. And at the water bodies, it's both.
So I have a question here. Maybe I missed it, but it's about the compliance and tracking the participants over time. And I keep thinking back about Rosie's presentation about showing the systematic, like non-compliance versus the random distribution, and how much that affected the possibility for elimination from, maybe you can correct me, was it like 15% to 75% possibility? So how are you tracking participants over time?
So we don't have longitudinal studies. It's all cross-sectional and then again cross-sectional in a way. In terms of systematic non-compliance, I'm sure it exists, yes. Again, it might be a bit different if people are offered MDA only or whether they offered a test and treat. But we have also people that refuse to participate in test and treat. So it's not the overall solution. And again, getting back to Amadou's awareness raising, education of health consequences makes people more ready, I think, to either participate in MDA or in test and treat. So the awareness, health education, and interaction with the community will be key to each coverage and compliance issue, I think.
Thank you very much for a very nice presentation and sharing your experience. I would like to know what is the reason that after rapid recrudescence will be manifested among children from 7 to 16 years of age. What is the reason behind this fact? Why this age category is evident for this? And also, is there zoonotic disease transmission, schistosomiasis in your country and Zanzibar, or there is a possibility that some primates play a role to maintain the disease, and if that is will help us also other countries to learn and experience from it.
I let Bonnie respond to the zoonotic part. Say again, the first one.
The first one is about recrudescence. The reason why recrudescence happen.
We don't know. That's why I put as one of the operational research questions, why are hotspots? We assume it's the amount of water bodies that do contain snails. We also assume it's people that are in close contact with these water bodies due to household chores or leisure activities. But we haven't assessed in detail why a hotspot is a hotspot and what all contributes. And we do know that the distance of people when they live in close proximity to a water body with snails, they have a several-fold increased risk. But otherwise, we do not really know why a hotspot is a hotspot.
Steffi, following up on that, did you treat in terms of snail control? Did you do the same in all? I mean, even in those that are hotspotted de facto because you keep seeing transmission, did you do any different to try to control snails in terms of habitat, changes, vegetation removal or other things, or using molluscicide?
Shall we first go to the zoonosis and then?
Okay, onto the zoonotic. Very good question on zoonotics because it's obviously quite a hot topic. There's two scenarios with zoonotics. There's this hybridization with other Schistosoma species, which can lead to these hybrid transmissions. There has been an importation of Schistosoma bovis, the livestock parasite, into Pemba, and we've identified that. There's no evidence for this integration at the moment, so that doesn't suggest to us we've got any problems with our livestock Schistosomiasis zoonotic transmission. But in terms of the monkeys, for instance, I think that's a possibility, and I think there's some evidence coming forward that there is some infections. I don't think rodents, we don't find haematobium in rodents in mainland Africa, so again, it's an aspect, as we move towards elimination, we're pushing this parasite towards its limits in terms of infection. It's something that does need to be considered and to be looked at as well. But again, it's a difficult, monitoring wildlife is really hard to do, but again,
In that sense, one-handed platform is very important to control
if there is evidence for it, I think we have to gather that evidence first before we start to actually, because we've got other priorities. It's about prioritization, but again, it's something that should be brought in.
Now that seems like the focus, but the question is, the praziquantel donated for humans, and then they are not donated for animals. Then where are we going to get drugs to treat animals? That's the challenge we are facing. And probably every country is facing that kind of challenge, unless if you are be able to buy by yourself.
That's certainly one challenge, and I think we'll come back to that, Charlie. I'm told that tea and coffee is waiting for us. Amadou, will you prepare to come back after the tea, coffee?
Good afternoon again, and welcome back to our next sessions. We have had this morning 2 presentations, and thanks for your contribution to these presentations. And now we will also now be hearing 2 other presentations in different angle, but all these presentations at the end of the day aims at elimination of schistosomiasis in Zanzibar. We all know that there is no one strategy that will eliminate schisto in any part of the world. So all these areas that we are trying to present here, it's our experience and our challenges, but also it's an opportunity to hear also from you what is your experience in these areas. And at the end of the day, we go out together with some recommendations and proposal on how we can eliminate schisto in our countries. So let me take this opportunity to welcome the 3rd presentation, or the first presenter for this second part of our presentation. And the presenter will be presenting issues of environmental challenges that we are facing. Dr. Charlie, you are welcome.
For those who are not in the morning session in the other rooms, I'd like to briefly introduce myself as briefly introduced by Said. I'm Charlie Ame. I'm the NTD project manager for Zanzibar. And this afternoon, I'm going to share with you some of the challenges we are facing to this end game of the Schistosomiasis control initiative, of course, in Zanzibar and probably elsewhere around the world. Next slide, please. Yeah, so, right. Oh,
yeah, you can sorry. Yes, yes.
Okay. I briefly discussed this this morning, the history of Zanzibar when it comes to the endemicity of schistosomiasis and the effort which has been taken over the years. So it took us some years back in 1930, let's say 1930, between 1939 and 1940, where there was an expert from UK, Dr. Mosley, who came to Zanzibar to work with the schistosomiasis, and who was working in an area called Muyuni in South Unguja. And he found there so much schistosomiasis going on there, and he made a dredge which then took out all the water and sent water, and then the water became dry. And he made an alternative of providing water source into that particular area. And then there were other initiatives which have been done over the years from that time period, and again until, say, in 2012, when we had a schistosomiasis control project, which we call it ZEST, and that was a big group. There was a consortium of the, we call it SCOR, the Schistosomiasis Consortium, the Natural History Museum, the Swiss TPH. So was a very big group, and we worked together to see if we can eliminate schistosomiasis in Zanzibar. And the result of those things have been shown by Dr. Steffi and also by myself and Dr. Boni in the previous presentation. So I'm not going to go to the impact of those initiatives we have done. So, but then in this particular period, we had snail control component, which we used mollucides, and thanks to bears who donated 3 metric ton of niclosamide for our use. And so then there was a time which we have done, let's say, snail control in most of the areas and different projects we had. Yeah. So, as I said, of course, before embarking onto snail control, we visited the potential water bodies, let's say the potential transmission site, all the water bodies, and we looked for snail species, Bulinas for our case, and so we identified the Bulinas, and then, so we had a protocol we were following, and then we prepared our niclosamide on 80 grams per 10 liters. So we used a Hudson sprayer, and also we used a motorized sprayer depending on the size and the nature of the water bodies to dispense or let's deliver niclosamide in those areas. So then there are challenges actually when it comes to the cost of niclosamide. For our case, we were very lucky. We received a donation of 3 metric ton from bears, but actually is really very costly, even if there are very few studies which has looked on the cost of the interventions, especially the snail control. But as one of the objective of our study was to show the cost of implementation of schistosomiasis elimination when it comes to combination of different strategies. And we used an average of around 100,000 US dollars across the 2 islands, specifically for the snail control. And of course, that also including personnel's cost and some other small cost in relation to snail control. So for our case, we applied niclosamide, let's say, focally. What does we mean? Imagine this is like in a water body. I may show you. If I can back, this is in a water body, for example. So we only applied in areas where there is water contact, there's human contact, where people, they use that. So we didn't spray all over the place. So that's what we call it focally. So we only do it focally where there's human contact, and one of the major problem with niclosamide, it tends to degrade when it's exposed to sunlight. So the activities doesn't last longer. It may take around 12 hours or plus minus, for let's say around 24 plus minus on that. So the snail, but then in a water body, the snail tends to move between different areas within us. With my small experience on working with the snails, they tend to follow like the wind. So if you're applying niclosamide in this way and the wind is blowing in this way, then you may find there are no snails here, but the snails are there. So this brings some challenges when it comes to control of schistosomiasis. So you need to have a local knowledge of how the snails move within a water body. And then the snail also, the snail we are working in, they are hermaphrodites, and that's meaning that they can mate, there's self-mate, but also there's a cross-mating between the different snails, of course, between 2 snails. But then this has an implication with when you want to control snails, meaning that you'll see in my subsequent slides, even if there's one snail survive your application of niclosamide, but at some times later may repopulate, and you see the population is coming back again and again. So, and again, if there are only one snail which has been infected, say then that one snail can, or less one miracidium can asexually reproduce, and southern of Sakai then comes out from snail. So one person, like this, in the previous discussions we had, and those particularly who are systemic missed during the MDA, and it might be that's infected. So one person then can infect the entire village if missed with the treatment because of the very rapid reproduction process which is happening there. So Zanzibar, as you know, is a small island, less Unguja and Pemba. They are very small islands, but there are so much water bodies in some areas. This is a map which shows the different water bodies which are there, and there are so much human contact in those water bodies. So we have big ponds, and then we have very small ponds, but also we have rice fields where the snails tend to breed there. There's a very good areas for breeding of snails on these rice pads. And there are areas which are filled with so much water lilies, and those are the areas which are very good for survival and production of snails. In the previous discussion, someone was asking about the potential of transmission of bovine schistosomiasis, or let's say animal schistosomiasis. We have seen few cases, and probably that were imported from mainland Tanzania, but now you see those animals are sharing water with humans, and then there's potential transmission of schistosomiasis from animals to humans. And there are so much areas where you can see people are washing their clothes, so there's so much domestic work happening on those water bodies. And so imagine if you are in this kind of situation when you want to control snails. So there are vegetations, there's a rice, and there are so much human contact, and the snails are there. Can you apply niclosamide in this particular area? Probably no, because otherwise then you can contaminate the rice field. So it's a very big problem when it comes to control of snails in different areas. And then the other thing which we're facing is about the climate changes. So when we're talking about climate changes, we're referring to the changing, or let's say changing of precipitation and temperature. These are two elements which are very important when it comes to transmission of schistosomiasis. Because, for example, see this water body, right? So this area and this area, this is the same water body, which tends to dry during the dry season. But the snails, as I said earlier on, not all of them can be killed. Some of the snails, even during the dry season, they tend to burrow into soils, and then there are some biological changes which is happening within the snail, and which can make them survive for some times. And when there's a reflooding during the rain season, when it comes like this, the snails come out and then they start the life. So again, when so that's the case of drought and rainfall. So you may see in a year there's areas where they tend to dry, but when the rain comes, they reflood. The reflooding, it happens, and then the water bodies comes out. And this has an implication. The change of temperature has an implication in terms of the production of the snails and the survival and the fendicity of the snails and the schistosoma as well. Because the schistosome parasite, the life cycle, let's say the biology, the life cycle of a parasite within the snail, it tends to be shorter when it comes to a little bit hotter. So the parasite production from the sporozoid, let's say from miracidium to sporozoid to Saccharia, it takes much shorter. It's not around, let's say, the 6 weeks, which is happening in normal circumstances. It's becoming very shorter, and then the transmission is becoming high. And you may find during the hot season, people tend to use more water as a recreational because of that. So there's a problem which is happening on that. Yeah. The issue of climatic change is much detailed from this author. You can read this Dekea in an international journal of environment, has explained in in this diagram. So the other thing that which is happening in Zanzibar, which is a challenge when it comes to transmission, there are so much, there's a project which is going on, which is an irrigation program, but in turns it created a very big water bodies. And this you can see there's so much contact which is happening here. And the problem with this now, of course, the transmission for schistohaematobium can go on, but it gives us a very big question mark when it comes to schistosoma monsoonite transmission. Currently, we don't have, but the big water bodies are the areas where other snail species may also habitat. And what if, the question is, what if the, for emergence, what if the biome filaria is going to be introduced here? Right, we don't know, but finger crossed for that not to happen. But that is a very big challenge in water. So this water body, which is meant for irrigation and which is delivering water into the rice farms, where you can see there's so much movement which is happening here. So if the infection comes here, and then definitely the infection will come here, which is bringing some challenges in snail control and schistosomiasis control ultimately. So we have a number of research, operational research questions which we'll need to discuss with you guys. And so what other strategies do we need for snail control? Do we need to do biological control? Using prawns and this crayfish. There are some species of prawns which tends to kill snails, and also there are some species of crayfish which tend also to kill snails. So do we need to apply those as part of biological control? But do we need to improve in chemical snails control and to have a specific compounds which can be species specific? And what can we do to maximize community involvement? Do we need to use the citizen science? These are the kind of new things which are emerging now. The citizen science, where we can engage community and try to educate and find and try to understand how the transmission can be halted. And then, do we need to do the environmental cleaning, the removal of water plant from water bodies, right? When it comes to identification of water bodies, do we need to use the remote sensing and satellite imaging to predict the water body size and probably when it's going to be dry out or whatever, right? So, but where do we apply different strategies, and where still they be most impactful when it comes to schistosomiasis? To reduce the snails, but then to of course, ultimately reduce transmission of the snail. But then the other question we're asking ourselves, when, in terms of the year, in period of the year, one should apply, or let's say, niclosamide, right? Because we have seen this water body, they tend to dry. So during the dry season, and then they flood out during the heavy rain. So what period of the year? And of course, sometimes they tend to dry out. You have to wait for what time in a year? This gives us some difficulty, and that's something which we need to discuss together to see if there's a solution for that. And can the interruption of transmission be achieved with concurrent MDA plus chemical snails together? So, because what we aim here is to try to see if you can do MDA simultaneously and snail control at the same time, see if they can have an impact. So thank you so much for, okay, can environmental management reduce transmission? We don't know, but it's something which can be discussed now, and we would like to get your opinions from that. Yeah, so thank you very much for listening in this also.
Thank you very much, Dr. Shali, for your presentation. As said earlier on, there are two types of questions. One set of questions is our questions that we have identified, and we put this as operational research questions. You will get an opportunity also to share your experience regarding these questions. but also after second presentation, which Dr. Fatma will present, you will also have an opportunity to ask questions related to this presentation and her presentation. Dr. Fatma, who is currently a director of preventive services in the Ministry of Health, but she has been working as a program manager for NTD for many years. You are welcome to present a political aspect of it, because now you have moved from technical part and now you are a politician, so we would like to hear what is your that angle.
Thank you.
Is that working? Yes. Yes, here we go.
Thank you, Saidi, for that candid introduction. So as I've been introduced, many of you know me. I'm Dr. Fatma Kabole. I'm now one of the directors for the preventive services in Tanzania, Zanzibar. Go up your presentation. This one. Okay. I was very happy when Amadou talked about health promotion. It's one of the key roles of the Ministry of Health promotion, prevention, curative and rehabilitation services. And health promotion is the key to improving the health of the population. As we all know, most of the African countries and many of the low-income countries rely on external funding, and we are having that dilemma now that we are pushed to domestic funding, where the resources are limited, and most of our governments have priorities. So when it comes to diseases that are low in prevalences, we really do struggle quite a lot. This is just to show you the scenario of the domestic funding. We do plan, and we plan very courageously, but but what we get from that, this is the reality. We get less than half. And as I said before, the government has priorities. Like you can see here, Shirley talked about this a bit. We are looking at food security. That's the priority of the government. So from the health sector, we really do have to struggle to make sure the food security issue and the disease control work together. So it depends on how much noise you can make. And I think now the directorate has enough noisemakers. So we are lucky that they are listening to us. This is Kinyasini. It's one of the areas where I think it was in Shirley's presentation since way back in the 1930s. It's one of the historical areas where prevalences are very high. And unfortunately, it's one of the areas where the rice fields are. So that's, I'm just bringing to you the grim reality of what it is in terms of disease prevention and control vis-a-vis the priorities from the government. These are the priorities for the Zanzibar government now. We have huge infrastructure improvements, digitalization of the health services, human resource development, supplies and equipment, universal health insurance, as well as improvement on the primary health care. So this has its own advantages, especially in the primary health care improvement plan, where it starts from infrastructure. The buildings are renovated. Unfortunately, their pictures are not here, but they are very impressive. So the government has taken huge loans to make sure the infrastructure is improved. There's human resource in the facilities. The whole thing is digitalized, the supplies and equipment. So we have to make sure we go with the flow, and how do we take advantage of that? So in terms of supplies and equipments for schisto control, that is all now, the government is going to make sure those things are available. How do we do that? It's upon us to make sure what we need is available. But the government has taken that upon itself to make sure all the supplies and equipment for the laboratories are available at the primary healthcare facilities. We are also having a very big improvement plan in terms of the community health volunteers, and now the government is actually making them salaried, which is a big, big plan. We have 2,500 of those, and they are going to make them 5,000 across the islands. So they were community health volunteers, now they are going to be community health workers, salaried. And we have managed to put an NTD package for them. So they will be having some skills to be able to diagnose, I can't say diagnose, but at least to identify clients and bring them to the facilities. So in terms of NTD elimination, I think that's a very big plus. So that the government has taken that upon itself. What are some of the challenges that we have and how do we mitigate those? Again, high-level advocacy and mobilization for domestic funding. We are still struggling with that, but for partners, somebody talked about what Steffi and the rest of the group is talking about is they are actually talking about the two islands, the two main islands. We are 53 islands, just to make the matter more complicated. And some of those islands don't even have health facilities. So to me, the big question is how do we access those populations? How do we make sure those populations access health services? So that's the big question. The priorities for those islands might not be accessing health services. They might still be suffering from schisto. They are very much cut off. We are very different to the mainland. Mainland, when you talk about far to reach or hard to reach patients or clients, is really the distances. But to us, it's the islands. And I've been to all those islands. And I've been to all the health facilities, 174 of them. Charlie will tell you some of those islands don't have schisto because he comes from one of the islands, but I've been to the rest of them, and they do have schisto. So the question now, and we actually ask the partners, is to help us to find ways to reach those islands. The people are really cut off, and they are very poor, they are suffering. We do need capacity in terms of research. We do need capacities in terms of the new diagnostics. Multi-sectoral collaboration, somebody talked about One Health. Yes, it has been strengthened. WHO is working on that. For us, it is under the Vice President's office, so it is very high up. Still, it is an issue. What is effective multi-sectoral collaboration and coordination? It's still something to be worked on. How do we involve the private sector? I think that will be a good way for domestic funding. So for me, the big question would be how would the private sector be engaged? Thank you very much.
Thank you, Dr. Fatma. Thank you both, Dr. Charlie and Dr. Fatma, and also for all the participants who have been carefully listening here. Very interesting. Before I give you opportunity to ask your question, it depends upon which angle you are looking at me. You can see here, Charlie was looking at the irrigation scheme as a source of multiplication of snails, but politically we look at it as a food security and safety. So this is now upon us. Let us see this challenge, how we can go about it. Now this is an opportunity for you guys to ask your questions. related to these two presentations, and later on also give your contribution to our research questions that we have here. Okay. Dr. Fatma and Shirley, you are welcome in this front seat there. Hata hapa. Hapa itakuwa hamna hii. Pale bora utapata microphone. Here we go. Thank you.
Well, it was an awesome presentation, and again, congratulations for the amazing work you're doing, guys. For Shelley, the questions about biological control, I think it has a potential. I would definitely open up broadly to think about what other species that could be, in addition to crayfish and to the river prawns. So the river prawns are super fragile, especially if you put that in a setting of low water quality or using agrochemicals. The crayfish are invasive, and so unless you can leverage on augmentation local species, they're problematic. But I have a lot of things that I'd like to discuss with you. One thing that may be worth considering is to use ducks as a other potential biological control agent, and other ideas that I'll be happy to, engage with you guys.
Thank you very much for that, and I will find you for further discussion. Yeah.
Yes.
Okay. Is it well known how STH is caused? Is this well known across the entire country that snails are causing it and how you get it? Or is these pockets where you say these small islands where it's difficult to get to, is this an unknown to them? Or is it one of those things that's pretty well known across the entire country?
It's quite difficult to say because, as I said, most of the work has been done in the two. I have a very loud voice, but it's difficult to say. And that's why I said we do really need support. Most of the work has been done in the two big islands. But we have 53 islands. Some of those are not habited, but we have at least about 10 of those which are big ones. And one of them actually has 25,000 people. So, and their source of water, the government now is in this big infrastructure push. They are also working on big infrastructure projects for water. So water would be available in the next 6 months or so. Most of the districts would now have water available. But the islands, again, it's an issue because they have to take the pipes from across, and some of those have very choppy water. I've been there, and it was really very difficult. It's like a 45-minute boat ride, very choppy waters. So, so it's not known. It would be interesting to find out, especially in those islands which don't have health facilities. So we have islands which have health facilities, smaller facilities, but we have those ones which are really cut off. And in those islands, we were told children actually go without bathing for almost 3 weeks. And it's because they don't have water. They use, the ponds and whatever is available, yeah.
Hey, I just have a comment about the snail control. So in Zanzibar, I think, is a cashew-producing country. And in Mozambique, they use cashew shells for snail control for schisto. And it's a natural molluscicide. Just something to talk about, consider. The other question I had, and maybe it's for the larger audience, there's been a lot of discussion in these meetings about using water body data to predict which communities are high risk, particularly if you don't have any data. And you've mentioned rice paddies and temporary ponds, which are, when we're creating geospatial risk maps, it's almost impossible to take these water bodies into consideration. And I just want to know if anyone had any good sources or intelligent ways of capturing those temporal water bodies and rice paddies into consideration. And I know Garba will say to me, community knowledge. And we just recently did a survey in Togo about hotspots. And when we did the survey about asking them about access to water bodies, we found there were communities saying, no, we don't have any fresh water bodies anywhere near this community. But they had 70% infection, and we were thinking, this is impossible. And it turned out that they didn't consider temporal water bodies as a real water body, because at the time we did the survey, it was dry. And so they were literally saying, well, we don't have a water body right here today, close to this community. And actually that was quite insightful, because actually community knowledge, yes, it's important, but you have to understand the nuances of that. So yes, that was my other question about water bodies.
So I think we need to respond. Yeah, you can respond with the word. The first one, which was you mentioned about the use of cashew nuts. We don't have those in Zanzibar.
We have more of cloves.
Yeah, we have cloves.
Cashew nuts in mainland.
Yeah, so this is in mainland Tanzania. Yeah, maybe you can try with cloves if it's gonna work. Yeah.
Could be tried, because cashew is one of the cash crops for mainland Tanzania. So we are within Tanzania. Tanzania is a very unique country with two governments in one country. So,
of course, we have in a very small scale, but not large, big enough to use as a control. And now I can see those areas where there are few, those cashew nuts are being destroyed because of the expansion of infrastructure and habitation as well. So, but basically we don't have enough to experiment that. And then the second question, I think, was for everyone in the room, and I don't know who can volunteer to respond with Anna's question. But it's true that, of course, we may rely on community knowledge in terms of identification of water bodies, but they are usually that is becoming one of the problematic area, because those water bodies, especially small ones, which are very temporary, or Steph, you want to join in. So you may find today they are here, tomorrow they are there, because of the different areas. And as you are saying, people sometimes do not consider as a water body, but they are good ones in terms of the transmission of schistosomiasis. Yeah.
I think it's an important point, Anna, and I think the possibilities that get into my mind are drone picture taking, which as long as there's somebody with a license and you can do it, they might capture them after the rainy season. And the other one is certainly also to collaborate closely with malaria control programs, because for them it's also important. Maybe not that much in the very rural, remote areas where nobody lives, but from Zanzibar we also know that they really try to map water bodies because of malaria elimination. So again, a cross-sector collaboration could be helpful.
Okay,
Thank
you. I have two comments. The first one is to react on biological control. So there has been a project in the 80s in Rwanda using Propterus aethiopicus to control snails around one lake. But what these fish did was to eat tilapia. Our tilapia, all tilapia in that lake was eaten by these Propterus, and our population doesn't like Propterus. So I think what prawns can do may be the same, and I don't think this can be accepted by the Minister of Agriculture or the Minister of Environment. So we have to think about this change of ecology and so on. Then for the islands, I think you don't have to deploy same package of interventions everywhere. There is a need for maybe assessing the feasibility looking at different archetypes of transmission to see what is feasible and how it can be done. Yeah, of course, you don't need same goal for every endemicities. You can set your goals depending on what is feasible. Thank you.
Thank you very much for those comments. And those, especially the first one, which calls for the multi-sectoral collaboration, so that Ministry of Health, of course, involve other sectors when they are planning for their thing. So we'll take it into mind.
Thank you. So my understanding around snail control is we need more evidence on the impact, the cost effectiveness, and feasibility. So I think that requires operational resource, and we haven't answered about it, so that's my understanding. And the other thing is we haven't exhausted about sanitation. So if we can avoid urination and defecation into water body, so there will be a possibility to decrease transmission significantly. So I think that's one area we have to focus on. Thank you.
Thank you. Again, thank you very much for the comments. Of course, there are few evidence, or let's say there are very limited evidence when it comes to the impact of snail control alone in the transmission of schistosomiasis. But for sure, when you're applying niclosamide, then the snail abundance going down. But because of this biological nature of the snails we are working on, even if, as I said earlier on, even if one snail survived application of your niclosamide, and if it gets escape and then burrow into mud, and then so when the rain comes again, is coming again, and then after some time you can see snail population is coming up again. So it's something which need to be done constantly, but then the challenge is it depends on the type of water body. For the water bodies which tend to dry, then it's very difficult because you will not kill 100% of the snails. So even, as I said, even one which survived will come back again, repopulate. So it's bringing some challenges. Dr. David, do you want to say anything on that?
I was going to say perhaps that's behavioral interventions.
Yeah. So we tried to put some, of course, during the period of the schisto elimination, we also had behavioral changes, which was a human-centered kind of. So we installed or we constructed washing platform near to types or near to wells. And we tried to engage community to avoid contact with water. So instead of going to wash their clothes in ponds or streams, then they have to use those washing platform. So we did also something on behavioral change. But changing of people's behavior is really, really very difficult. We went to a school somewhere in Pemba, and we asked teenagers, why you are going to ponds or to stream to wash your clothes or your utensils, and the answer was is easy for them, but of course was not good one. Say because when you wash your clothes, you are using less soap because the water body, the water is soft, so you're using less soap. And when also they are going there, it's like in a competition to clean their utensils, so your utensils become much brighter rather than washing using the tap water. So there are some economical issues, but also there are some other social issues, and it's really very, very hard to change people's behavior. And this, of course, I remember Dr. Amadou repeatedly say that the schistosomiasis is a behavioral disease. But it's really, really very difficult to change one's behavior. Yes.
May I just add something on the behavior change interventions that were and are still implemented within research projects. So Charlie mentioned these washing platforms, which I personally think have been a great success. They are really used. People like them for the reasons Charlie mentioned, because A, they have safe water, B, they are within within the village, so when children go and wash, they don't go down to the river where the mother can't see them anymore, but they are within the village, and the mother is still kind of feeling securely about the children. They can use powdered soap, which is not swimming away, and it's obviously cleaning the clothes better. But the issue also with the washing platforms is they need to be maintained. So the communities again need to take action to maintain them, or somebody from outside needs to do, because otherwise they are falling apart after some years in the climate. The other thing we observe is also that the people that live around these washing platforms, they are using them a lot, but people would not walk kilometers to use these washing platforms. So there need to be plenty if they really need to have an impact. So the other point I think that was mentioned by the lady in the front here is about the knowledge of people. I mean, you were talking about the small islands. For the bigger islands, people have a lot of knowledge, or they are aware about schistosomiasis, but when it gets to the exact information of how it is transmitted, the knowledge decreases steeply. So many of them do not even know it's a snail that is involved in the transmission cycle. They might know that they get it in water, but there's also a lot of other kind of assumptions where they can get schisto. So again, health education is key in if you want to interrupt transmission, in my opinion.
When you were saying that the parents their kids would be in trouble when they came home and said, I've got schisto, made me think that it was a little more widely known, and parents are upset with their children because they went to that source of water and they knew they should be.
And what we now observe with a lot of, like we have so-called kichochos, the Kiswahili word for schistosomiasis, we have huge outreach and health education base in schools within the behavior change programs. So the children that are targeted by behavior change actually have quite good knowledge. And when we go into the communities interviewing the adults, they have low knowledge. And then two children just come and tell the parents how it works. So it is quite interesting to see like that children nowadays have better knowledge about schistosomiasis than their parents do have. While the parents were the ones who probably had it like 20 years ago.
In Bangladesh, that's a factor that's improving SDH, is that the children are in a little doctor's program and they educate their parents and other people in the schools, and it's considered a prestigious position to be a little doctor.
Yeah. So but the other point, of course, that Charlie mentioned is even if people know, they need alternatives. If there's a well and it's a small girl, how can she pull water from the well? She will go back to the river because she can easily access it, but not the safe water from the well. So if there's no alternatives, behavior change, how can you do it? So,
Okay, yeah. My comment is to encourage the authority of Zanzibar, because it's already nice to see how the control manager and the decision makers are on the same table and around them, the partners and so on. And that's something to encourage. And I think you don't have to be, you need to be patient. That's not something you will just be destroying in 2 weeks or two months. That's a long-term process. You are starting now. And if you are agree to be in the same room, on the same table, discussing the priority of the country and taking now the ownership of the result from this project and taking carefully the situation of Zanzibar and the particular profile of the environment, you will find a good solution. Nobody will come and build your elf for you. That is now time to set an agenda to take into account what you get from this project and build the thing smoothly and correctly, taking into account the complexity of the of the relation between the Ministry of Economy and Education and Health and so on, taking all those things into account. And I think you are in a good way. Just be going. Yeah, thank you.
Thank you very much. Thank you. I'm coming. Dr. Gal.
Thank you, Fatma and Shali, for the presentations. So I would like first maybe to comment on your last question on involvement of private sector. So I think this new project, this irrigation project is maybe led by a private, I would say, company or a company, public-private company. And WHO recommend when you have this kind of big projects to have mitigation actions supported by this company. So I think there is a need to make advocacy with this company so that they can support the monitoring of the schisto situation in this area. Because my fear is that there is no way the prevalence will increase in this area. Definitely. There is nothing to do because the parcels are very limited. They are small. So it's difficult to utilize big machines. You see, people working in the irrigation field, you have this availability of boots and maybe changing their working, I would say, behaviors, which is going to be difficult because people are not going to move from the irrigation field to toilets at home to urinate. They are going to do it, and before going back home, they are going to clean themselves in the canal. And people, we are going also to think that this canal are close to homes, and they are going to utilize these canals for water. So this is what I've been seeing in many, many countries, and I think this dialogue with this company for them to support the program with MDA, with all the interventions in this area will be important. It's good to have food, but it will increase also the prevalence of the disease, and mitigations action are required. My second point is with regard to snail control. And I would like to respond to Anna, because when you insisted in this village, people told you in this place there have been a pound which lasted maybe 3 to 4 months and disappear. And it's largely enough for schistotransmission to occur. But people know, because you have different type of transmission archetypes. You have the temporary ponds, you have the permanent ponds, you have the lakes, you have the irrigation. Each of them has its own transmission, I would say, a pattern with distribution of the infection in age group. It's completely different. You see, this 70%, when you go and assess the situation in adults, you're going to see it's low, because the contact of adults with these small ponds in the village is really limited. So I think it's important maybe to try. First, maybe doing MDA when these ponds are dry, because there will be no reinfection at that time. And with regard to snail control, you can use granule of molluscicide on the dry ground, because when you have the rainfall, immediately the snail can release cercaria. But when the rainfall is going to coincide with presence of molluscicide, this first, I think, shedding of cercaria can be limited. So there are dried and granule of molluscicide. They are recommended in the WHO field use of molluscicide manual. You can see how you can utilize them in these temporary areas so that maybe the transmission can be reduced. Thank you.
Thank you very much for the two recommendations. Yeah. Here we go, Sana.
Thank you. Earlier this morning, in the session in the morning, we had the presentation from Indonesia, which was very different from how we do our presentation, and that triggered me that how we advocate for Schisto needs to be a bit different, because if you're just doing policy documents and PowerPoints, sometimes it's not easy to get the policy makers' attention. But if you sort of present it in a way that they're able to see why they need to do it, maybe we could get more resources from our governments. And my other point about BCC, I think different communities have do things differently for different reasons. For example, washing clothes and going to the river, it's a social thing. So they may not want it nearer, because going down, that's where you get the gossip, and different people go to different areas. And if you have water baths, but you don't have somewhere for children to swim, they still also want to socialize. And how they socialize is by going to the river. So if there's no swimming pool, it's hard to say do not go to the river. Thank you.
I don't think if I need to respond on this. These were only comments, right? Yeah.
Quick comment again to the socializing at the river. So this was exactly something we tried to address with the washing platform. So they are huge washing, let's say it's a 3-meter diameter, and it has like a sitting area on the, how do you say, on the border?
Yeah.
Yeah. So people could sit and socialize, and that's exactly what they do. There's about 10 to 15 people that sit and wash together, and that's exactly the point about socializing. So it can be addressed with the washing platform.
Yeah, but just the other thing when it comes to snail control, based on the clip you have seen this morning, there are 2 different species of the snails. Right? So our snails are aquatic, restricted aquatic, but the snail type that they are amphibious when it comes to Oncomelania. Which is in Indonesia. So so you can see them on the dry land, or also you can see them in water. So you can even pick up, and then if you clean the environment, then it's fine. But for our case, then you have to apply chemicals or other methods we have been discussing there. So it's a little bit different scenarios when it comes to snail controls in those 2 particular areas.
Looks. Yeah. We're taking 2-3 more questions.
Okay, thank you so much for your great presentation. Luckily, we have now community health worker, as you mentioned, that they will get paid. I think the first package for this community health worker will be the community engagement. I think it's really key and a pillar really to, not only for cysto, for many diseases, because most often these community health workers, they are living in the same community, same area. So if you can develop like maybe some regular focus group and really let people know that they are the first partner of their own health. So if I wanted to take an example, for example, for malaria, sometimes if you can give mosquito net to people and you do expect that they will sleep under this net and then the prevalence or the incidence will decrease, but if they are using this net for fishing and other things, or using for other things, so this is the lack of community engagement. So I think the first biggest package for this community health worker is really to see how they can really engage the community through different activities because they are living in the same area as these people. Thank you so much.
Thank you very much, and I think now we have...
Before you close, there was one additional question from a colleague there when it comes to construction of toilets, or let's say the hygienic part, which for some reason just went away, and then now comes up. So that we did try in our projects, in the behavioral component, we did try to construct urinals and some small toilets close to water bodies so that kids or whoever who want to pee then can go there, but it didn't work very well. But what has been seen in other areas of the world, even in developed countries, people, when they feel like they want to urinate, and once they go in contact with water, it's just something like natural calming. It facilitates them to pee in water. This has been seen. You can see peeing in water. You can see in big pools in developed countries, even in developed countries, when you test, you can see water is contaminated with urines. But then it comes back to the biology of the parasite. So if someone is infected with the schistosomiasis, and once it gets in contact with water, it's like stimulate to pee in water so that the life cycle has to get on.
This is why I think this is why one of the nursing care for retention of urine is to leave the tape dribbling.
Just to add on that complication, it's the uniqueness of the islands, apart from us beautiful people. So we have groups of people where their main source of income is fishing. And they actually move around the islands, and they don't stay in houses. They have like temporary dwellings, and they don't use toilets. Like, I've been around those islands, and we have asked that many times, and they say, we don't feel it's necessary. So they pee in the bushes, in the ponds, in whatever places, but they would never have like permanent houses. They move around. So that's one of the uniqueness of living in islands.
Thank you very much. Number one, let us clap for the presenters. Thank you very much. And number two, having had and contributing to the 4 presentation, which was very dynamic in different angle, from research point, interventions, diagnostic, environment, and politics. These are all together. If I give you an opportunity to tell us one take-home message toward elimination of schistosomiasis, who would give that statement? Take-home message. Take-home message, and then off we go. Okay, so the take-home message is that in order to eliminate schistosomiasis, it is not a Ministry of Health alone. It is Ministry of Health, Ministry of Agriculture, Ministry of Water, and above all, it's political engagement. But again, also we have heard here that community involvement and sense of ownership of these projects that we are doing is very important. And we should all put this in mind if we are really aiming at elimination of schistosomiasis. Thank you very much, and thanks for your participation.